Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs.
Just having our volunteers really rally and really go out in the community and grab other volunteers to really help us push our mission and help us push the work that we're doing. So we're very heavy on volunteer base. Our volunteers really lead the mission, really lead the focus in the work that we're doing here. And so all of that helps us gear up for a big event that we have in April called our Purpose Ride event. Just some research information that we're doing, just so people know, where funds are going and all the great things that's happening. Of course, we're advancing research and we have patient service. We have things available, options available for all of our patients. So don't feel lost that you have to do things alone. And also, like I told you about the building community piece, about the volunteer piece. So all of those three is what makes the PanCan mission. Like I said, our Purpose Ride event over 26 years ago have been together and really striving within the community. PanCan Purpose Ride isn't just a one-day event, but it's a movement. It's a chance for us to rally and really advocate in our community. So we have one event on April 26th in all of our affiliates. So it's not just here in Atlanta, but in Dallas, in Houston, we're having different walks to really bring the awareness to the different communities and different walks there. So as I stated, PanCan Purpose Ride is really driving the PanCan mission. We're creating a world in which all patients with pancreatic cancer will thrive. That's our ultimate goal, and that's what we want to really advocate on Purpose Ride Day. And I just want everybody again to save the date, April 25th, right here in Atlanta. We'll be at the Perimeter Mall. We're having a big walk. If you would like to volunteer, if you'd like to sign up, get a team involved, we have information that's going around the room. You can also stop by our table, and we would love to see you out. It's a Saturday walk around the mall. It's definitely it's going to be a fun time, family fun event. So we would love to see you out. Love to have your teams come out as well. Thank you guys so much.
That's April 2026. So no excuses. We know you don't have anything planned yet. So I'm going to speak real quickly to Cancer Support Community and then pass it off to Dr. Sur. If it's your first time here, please don't let it be your last. Come attend some programs. We would love to have you here in person. We have a ton of stuff available virtually as well. You can find more information on all of these programs on our website, cscatlanta.org. If you can't attend a live person, we have a live program. We have a video library of over 200 recorded programs that you can access at any time. Most of those are facilitated by Northside Hospital clinicians and physicians, so you know it's a trusted resource. And this program will be recorded and added to that library as well if you want to reference it or share it in the future. So again, these are just some of our programs. I won't go over all of them, but I will encourage you, please check out as you walk by the PanCan table. Also check out the flyer wall where you can see a complete list of all the programs we offer. We really do so much here, both virtually and in person. So take advantage of what's available for free. All right, and then, check us out on social media. Give us a like, give us a follow. All right, so I'm going to pass it off to Dr. Sur to get us started for today's presentation. Thank you so much for being here, Dr. Sur.
Hi, everybody. Let's figure out how to do this. Do it here, right? Do we have a thumbs up from them that they can hear? Hi, how are you doing? It is so amazing to see you all. I know some of Dr. Abdallah's patients are here, all of our staff. I've got some of my patients are meeting, and it's making me cry because I'm just like, this is like worlds colliding. I like to try to make every patient feel like they're my only patient, but it turns out that there are others. So I wanted to, it's kind of like my children. I also have to make sure each of the daughters thinks that they're the only daughter that I have. And, but no, taking care of patients with pancreatic cancer is my great privilege, and being able to speak to you a little bit today is also something that I'm really honored and proud to do. I wanted to speak a little bit, not too much about myself, but start a little bit with, especially for those of you who may not know, why do I do what I do for a living? So when I was a high school student at Hunter College High School in Upper East Side in Manhattan, I felt a lump in my cheek. And so it turned out we went to a bunch of doctors, and I actually had a tumor in my parotid gland, which is one of the salivary glands on the left side of your face. And, to me in that time, my parents both have PhDs in physics. They met doing physics. They have PhDs from the University of Pittsburgh. So my parents were like the smartest people in the whole world. But the moment that the doctor said your child has a tumor, all of that went out the door. And I saw these two really brilliant people just become just completely melt, right? And those were the days before the internet. So they were going to the library, getting anatomy books, reading about what is this thing, what's going to happen. And of course, I didn't get any of that stress, but I went through the fun part of saying, oh, there's a tumor, and I got excited looking at my MRI. I brought it to my 9th grade biology class. I said, look, I have this thing, isn't it cool? And nobody else thought it was cool. But then also, I ended up having surgery. This is Dr. Noel Cohen. He's passed away, but he was the chair of the ENT department at NYU for a long time. And I just remember what a powerful thing it was to be able to be that person who in the time of uncertainty and fear is able to bring a little bit of hope, a little bit of comfort, knowing that they can't guarantee what's going to happen, but knowing that they can help you get through and understand what's going on in your own body. That was very powerful for me as a 14-year-old, 15-year-old. And it was kind of the beginning of thinking about I might want to do this. I was an undergrad at Harvard and Cambridge, but in one of the summers between freshman and sophomore year, I ended up going back actually to Mount Sinai, which was a couple of blocks away from Hunter. If those of you know the Upper East Side, they're closely related. And just as luck would happen, I ended up getting assigned to shadow a surgeon, Myron Schwartz, who's the kind of father of liver resections and one of the fathers of liver transplant surgery on the East Coast. And I knew from that summer that I had to be in the belly in some way. And I was like, forget the head and neck. This is where it's at. And so, I knew that this is what I wanted to do. I wanted to work with people who are sick, and I wanted to work in the abdominal area, in the areas of the pancreas and liver. And I ended up going to medical school and finishing my general surgery residency at Mount Sinai. And this is, I think, less about kind of what I did. I don't like to really talk about myself. I wasn't really raised that, but I do think it's important for patients to understand what the training is, because we're in a world where everybody can say anything they want. I had a patient earlier today who kept saying, well, I was reading this on the internet. We're getting lots of sources of information. And we're in a climate where we don't really know who do we trust, who can we trust? Because we're hearing so many things from so many people. So I think it's important for people who have trained to make sure that everybody understands what it is that we go through to get to where we are today, because it doesn't happen overnight. So I did 4 years of medical school and then 5 years of general surgery residency. I took a general surgery written oral boards in the oral board process. So first we take a multiple choice test, but then in the oral boards, basically we walk around to rooms where experts are sitting there, and then they ask us whatever they want to test our knowledge about all these diseases. So that was first. And then following that, I went to the University of Chicago for a 3-year fellowship in complex general surgical oncology. Surgical oncology is the study of how surgery can be used in different cancers across the body. So we're trained broadly from, I wouldn't say head to toe, but almost, we do thyroid cancer, breast cancer, everything in the belly, colorectal cancer, soft tissue, sarcoma, melanoma, and even adrenal tumors. So it's a very broad training, not only in surgery, but the medical approaches. And I think that's also really important to remember, because my job is not only to think about, can I cut it out, but should I cut it out? And that's an important distinction when you're seeing a surgeon. It's really important that we don't just cut because we can. And so that was a 3-year program. And then I took a separate surgical oncology boards, again, a written exam, and then a 5-room because they had to make it even harder. So that's a 5-room exam, where you're running around and just, again, experts in the country, leaders in the field asking you, well, what do you think about this? What would you do if, Mr. Smith came in with this problem? And then grading you. Then I went out into practice early on. My family's from New York. I was committed to being in the New York area. I had a position back in the Mount Sinai system. I was the chief of surgical oncology at one of their hospitals. And what I struggled with is I was very busy, but I wasn't able to necessarily be practicing in the best ideal environment for my patients. And so I really went on a search to say, where can I be where I can practice and deliver medical care the way I want it to be? And what would that look like? Well, on the one hand is you want to have a team that's a cohesive team of experienced physicians that you work with. You can't do it alone. There's not just me, as our patients can tell you, there's a whole bunch of other people involved. And so you need those people to also not only be great doctors, I'm sure they are, but also be experienced in taking care of these illnesses. So that's very important. We need a lot of help to do what I do. Sometimes I say I'm running around like a headless chicken. So in order to focus on the things I need to focus on, I need a big team to help me with all of the other stuff that is critical to patient care. So that's our, advanced practice providers. We have a few here. I think Ariba's back there, and then probably a few others on the phone, online. Nutrition is so underlooked, as you know. That having a oncology trained dietitian as a part of the team, that is the ideal, but most patients in America, believe it or not, don't have access to that. We want to have a team of inpatient nurses that are comfortable and familiar with these operations so that it's not their first time looking at a drain. And, that has to do with, their ability to call me if there's an issue or a concern. And then we want the hospital to be a place that supports advances. And, I'll talk a little bit about robotic surgery later. And then, primarily there's also just frankly a statistical question of having access to a large number of patients with rare diseases, because it's only when you get out into practice that you realize, wait a minute, pancreatic cancer is not as common as breast or colon or some of the other tumors, prostate cancer. So even more so in those cases, of course, in those cancers, you also need to find an expert, but in pancreas cancer, you also need to find someone who deals with a lot of patients. That means your catchment area has to be broad as a physician. And, I think that was something that when I was looking around, there was not that many places that I could find all of that. I never thought I would be in Georgia. Okay. I am like Upper East Side, like uptown girl, riding the subway since I was 10. I drove over here with the staff and I said, be careful. I only started driving in my 30s. So I really was not looking to move down here, but I also needed to be in the place where I could do the best possible work. And when I saw, as many of you know, Dr. Abdullah, our founding partner, when I found that, he needed to grow his program, I said, well, this is the opportunity of a lifetime. And how could I, not take that? And so now I'm very privileged to be a part of this program with Dr. Abdullah and Dr. Burnett. And, we see a high number of patients with pancreas cancer. We have been certified now for a couple of years by the National Pancreas Foundation as a center of excellence for pancreatic cancer care. That's really reserved for only a few centers in the country. So enough about me. Let's talk about what we're here to talk about with pancreas cancer. But I hope that was helpful in some way to know a little bit about why we have to seek out care at institutions that can deliver it in the proper way. So I think it's important that while we're all gathered here today, we do remember that the incidence of pancreatic cancer is still rare, so that we're not running around thinking that everyone's going to get it at this, at the first time they have a little indigestion. So we can't be that nervous. It is 3% of all cancers in the United States. And the average, risk of getting it in your lifespan is still much lower. This may look like a lot, 1 in 56 or 1 in 60, but for breast cancer, it's like 1 in 12 or, even higher. I think now 1 in 8. Don't quote me online, but it's basically, it's much more common. And, I always say, well, we're all going to get breast cancer, but, pancreas cancer is pretty rare. So that is something to remind us of, but we are seeing some increasing rates, especially in younger people. Now, some of that might be that we're detecting it a little bit earlier, or more people are getting scans when they have symptoms. But I think just, all in all, it means we have to stay attuned to what's going on in the population. It's projected to be the third leading cause of cancer-related death in the United States by 2030. This is information that I got from the PanCan, website. And, let's talk about 5-year survival. I don't like, many of you know, my patients know, I don't like giving numbers all the time because the numbers are so inaccurate about each individual person in front of you. But if you ask me, yes, it is true that for all comers, the 5-year survival, which means how many people at 5 years are alive, right, is around 13%, which is pretty low, but it's much higher than what it was 10 to 20 years ago. And I think that's what's really important to remember. The other thing I tell everyone is remember that that number includes everyone, including the 87-year-old who has a bunch of medical problems, who's really sick, and who's probably going to have a hard time getting through treatment, right? So we want to really be careful when we see that number, not to panic and think that it's about what's going to happen to us, right? Because everyone has the potential to be an outlier, right? So obviously it depends a little bit on whether your disease is localized or has spread to other parts of the body, but just remember that statistics about prognosis don't tell us about what's going to happen to you. What are the risk factors for pancreas cancer? So we know some of the stuff that causes a lot of other problems and other diseases too, right? Smoking, obesity, diabetes, chronic pancreatitis, we know can be a risk. We'll talk about mutations in a little bit. I do think that when we're talking about early onset cancers, I always want to raise a point as somebody who has little kids that, I am always concerned about our exposure level to toxins in our environment. It's hard to prove, but when we have our coffee cups, plastic everywhere, I mean, our culture now, we can't get around it. But we are exposed to lots of chemicals in our everyday life. And I think I'm hoping that as we realize this and have data to prove this, we'll be able to kind of make some changes on the national, international level to regulate some of these things so we can have less exposure. But I think probably it's most important to make sure our kids are not exposed to some of these things early on and trying to do as natural as we can, but also knowing that we can't go nuts because it's really a part of our environment. And usually most risks are multifactorial. That means a lot of different things come together. A little anatomy. My patients know I like to draw pictures. It's part of the things I like to do. Some of them, they'll come for follow-ups. And I'm saying, can I draw the picture? They're like, please, we have our picture. You don't need to draw another one. I don't know how to talk about this disease without having a picture. But the pancreas is a deep organ. It's all the way in the back, which is why we often don't feel things until they've grown. We talk about it's shaped like a fish. It has got the head, the neck, the body, and the tail. Running through the head of the pancreas is the bile duct and the pancreas duct. And the pancreas sits nestled within the first part of the intestine, the duodenum. So I call it spaghetti junction of the upper abdomen, which makes it kind of complicated. And another thing that we need to talk about is those blood vessels, right? Because those blood vessels make a lot of difference as to whether we can do surgery and what treatments we might need to do before surgery to help us get the tumor off blood vessels and do the operation in a safe way. The pancreas is primarily has an exocrine function, which means it produces digestive enzymes like lipase, which helps you break down fat. And that enzyme is secreted into the duct that meets in your intestine. So some of our patients, as Allison's going to mention, we will give you extra pancreatic enzymes if your pancreatic enzymes are having trouble getting to your food. But it also has an endocrine function, which means that it makes insulin, and that's secreted into your bloodstream, so that's, as we'll get to later, like one of the signs and symptoms of possible pancreatic cancer is new onset diabetes when you're an older adult, or I'll say even middle age, right? So let's talk about screening. A lot of people say, wow, I'm so worried. I saw Alec Trebek, I saw all the stuff on the news, D'Angelo, right? How can I be tested? What can we do? And the problem is that routine testing is not recommended for the general public. You might say, well, why is that? Well, because with screening, we always have to think about if we do it to 10,000 people, how many people are we going to help and how many people are we going to hurt, right? Because screening is not really free. And what does that mean? So there's, first of all, not a good blood test to justify screening everyone. I have a couple of patients a year I see where somebody asked for their doctor to just check their tumor markers, and now they're mildly elevated. And so what are we doing? We're doing scans, we're doing MRI, we're doing this, we're doing that, maybe a biopsy, we're doing all sorts of things. And it might just be that that number for them is just God made them a little differently, and their number's a little higher, and it doesn't mean we need to do something. So we've got to be careful about over testing people who feel fine. The other problem is CAT scans have radiation risk. As we know, some of our patients have allergic reactions to the dyes. And so we don't want to cause harm by scanning everybody if they don't have any symptoms or risk factors. But some people do need to be considered for genetic testing. And who is that? There's going to be patients that have a strong family history, especially of early onset, which we say is less than 50, of any kind of cancer really, but particularly pancreas cancer, breast cancer, ovarian. Those are ones that make us think of some of these syndromes. I always say it can never hurt to get a referral to genetic testing, right? Because a genetic counselor is going to be able to look at your history and give a better sense of, is testing recommended or not? And if it's not, okay. And if it is, then, why not think about proceeding? And, with that, you have to understand the risks of anxiety of knowing a diagnosis versus just leaving it alone. But I think most people will opt for testing if they're offered. And if you test positive for a mutation, then so those patients can be considered for MRI, something called endoscopic ultrasound, which is a procedure where a GI doctor will get up and close through your stomach onto the pancreas to look at it, and also blood work. We typically start that at age 50, but in rare cases, we would start it sooner. I think the main thing is if you've got a family history, talk to your doctor about whether genetic testing is something you should consider, because it's really the cost of it has come down in the last 10 years. So we're offering it more and more. And I just have this one extra box, which is most pancreatic cancers are not caused by a genetic mutation. And that's important. My mom had cancer herself, and she at the time said it wasn't pancreas, but she said, well, why did this happen? I don't have any family history. Most people with cancer don't have a family history. So it doesn't mean that you can ignore signs or symptoms. What are those signs? So early detection is difficult because the pancreas is deep, and it's really got to cause a problem for you to know that you have something going on. We always talk about vague symptoms like abdominal pain, back pain. They're difficult because so many things cause abdominal pain and back pain. So I usually just say, there's got to be some, I guess, common sense approach, which is it mild? Does it get better, right? Those are things that are more likely to be benign causes. But if something is, if you're someone that's never had a complaint, and now, you're 47 or you're 56, and now all of a sudden there's something new and it's not getting better, and maybe it's getting worse, that's something that needs to be escalated, not just going to your primary care, but if it's not better after some basic workup, coming back and saying it's not better, what else can we do? Unexplained weight loss, always a concern, a little confusing now because we've had a lot of patients on the drugs that are causing weight loss, and then it becomes confusing. Well, is the weight loss from the drug or is something else going on? So it's interesting that has happened just in the last couple of years, where we can't just assume that rapid weight loss after starting a drug, a weight loss drug, is because of the drug, especially if there's any other symptoms. New diabetes, I talked about. Indigestion, bloating. The classic finding for having trouble with pancreatic enzymes is floating oily stools. We don't always see it, but if you see it, definitely something to tell your doctor about. And then lastly, probably for most people with tumors in the pancreatic head, the way we find out about it is because one day they realize they've turned yellow. And that's because the bile duct gets blocked. The bile duct backs up, and the bile that should be draining into your intestine is now coming up into your bloodstream. So you can see it in your eyes, your skin, and sometimes in your urine and stool. And so I think the main take-home points is that routine tests do not always pick up pancreatic cancer. So if you have persistent symptoms, we need to keep working those up. And remember, I'm not going to see you most of the time until there's a diagnosis. So really, this is a call for for patients to speak to their primary care doctors if something's not getting better, because endoscopy and colonoscopy is great to rule out stomach cancer and colon cancer, but it will not look at the pancreas. And CAT scans, MRIs, if they don't have IV contrast, are also not going to always pick up a pancreatic mass. We'll get to that in a second. So again, if I could be on a podium, which I am, I guess. So I would say that everybody with persistent abdominal symptoms needs an endoscopy, a colonoscopy, and imaging with contrast. Okay, that's like my take-home point. Here's just an example. These are two different CAT scans. This is without contrast, and this is with contrast. So you can see the difference, right? It's really, really different. This is like all gray, one color gray, whereas with contrast now we can see blood vessels, we can see organs with greater definition. So that's why contrast is so important. Okay, next, usually, by the time you're now in the workup, you're being sent to a GI doctor who's going to do an endoscopy. If you have a blocked bile duct, they're going to be putting in a stent to a little tube to prop it open. And then an endoscopic ultrasound with a biopsy is really key so we can figure out what type of cancer is the problem. And this is another important talk. When we are here as PanCan, we talk about pancreatic cancer. Most of the time what we're talking about, although I know PanCan includes pancreatic neuroendocrine tumor, but there are two different types that we primarily see in the pancreas. One is pancreatic adenocarcinoma, and that's when the media talks about pancreatic cancer, that's usually what we're talking about. There's another entity called pancreatic neuroendocrine tumor that can be very confusing because I've had many patients be told, even by doctors, that, well, that's benign, as you guys, I'm sure, have heard from your patients. And that can be very confusing. It's not benign, but it's much more slow growing, so that oftentimes we can even leave it alone and just watch it. So most of this talk is about pancreatic adenocarcinoma, and I think it's really clear, and also why when some people say, well, my friend has this and this is what happened, just remember the friend, even if they have the same exact type of cancer, you might think that it's the same, but it might not actually be on the biopsy report. So we have to be careful about that, the grapevine. Sometimes the biopsy may miss the cancer. That doesn't mean we can throw a party, right? Because if we're worried about it, we may need to do another biopsy, and that's okay. We have to do whatever we need to do to get to the right answer. So I talk about the tortoise and the hare, because this is the frustrating period where you're like there, as a patient, you're hearing there's a mass, there's something going on. And we can deal with anxiety a little bit if we know what the plan is, but that period where we don't even have a plan and we're waiting for this and that, it's very frustrating. But I always say, not that we want to be a tortoise, but we also don't want to be a hare, right? We don't want to rush through things so quickly that we've made the wrong treatment plan. So oftentimes now the patients are being referred to other doctors like me or a medical oncologist to get lab work, the tumor markers, a better CAT scan to look at the blood vessels, even better. A PET scan is not always needed, but could be ordered if there's some additional findings. And then occasionally we'll do something called a laparoscopy, where we're just going in to look at the situation to make sure we're not missing anything. So this is the part that's really overwhelming, but it's really important that we actually take the time to do it right. Okay. Also important in this period is the further investigations into not just the anatomy, but also how is everything else. So Alison in a second is going to talk about nutrition. How do we improve your nutrition? Because many times now we're meeting someone who's lost weight, who's not feeling good, who might not be eating well. How do we get them ready for what's next, whether that is surgery or chemotherapy? We have to look at their other medical problems. And we have to look at their emotional health, right? It's a neglected part of patient care. Often as we are so busy talking about the medical stuff that we've forgotten to tell you, it's going to be okay. We're going to figure it out. Let's do this together. And I think, that's an under-noted kind of area in patient care, which is what can we do to help you with emotional resilience? We oftentimes leave it to you to figure out who do you need to go to, but what can we do to build up that resilience? Because it is needed, because it's a journey. It's not usually get a treatment plan and finish up and be done and return to life as usual, as all of the patients here can tell you. Psychosocial support is essential. I sometimes meet somebody who lives like in a trailer and has no family and no friends. And even if they have a tumor that I can operate on, it is very hard to imagine that they can get through treatment in that situation. And so then we're really looking at what can we do with our navigators, what can we do to help this patient build bridges and get some support to see if we can get them to where they need to be. Spirituality, I've learned a lot from my patients, and everyone has got different backgrounds, and that's a very personalized thing. But I think in any way that you can, to look at the bigger picture and remember that we're all part of something bigger than what we're saying or what we're seeing that day or facing that day. A common question I get at this point is, well, what stage am I? And I always say, well, actually, staging is very complicated. True staging is something that is even hard for me, and this is what I do for a living, to have completely memorized, because we're looking at how deep is the tumor on every test that you had. Do we think the nodes are there? Do we think that, is there any spread? And the other issue is that staging can change in time. So I usually think it's better to think about things as early, middle, or late, with early patients having small tumors, being relatively healthy, not having any signs of spread, the tumor's away from the vessels. In the middle category, these are patients where the tumor looks a little bulkier, maybe there are some lymph nodes, the blood vessels might be involved. And the late stage patients, I should say, are the ones where we're really concerned that, we're seeing obvious signs of spread outside the pancreas. But the question is a hard one, because I've seen so many patients where staging changes. It might be that we overstage you, where we're concerned it's more advanced than it is. And it might be that we understage you. So sometimes I think the better question is, what do we do next? Like, what do we know and what do we do next? And not worrying too much about, is it a 1 or a 2 or a 3 or a 4 right this second, okay? So let's look at treatment options. So what's in our toolbox for treatment? We essentially have, for the most part, 2 types of treatment. One is what I call systemic or whole body treatment. That's not just going to treat the pancreas, but it's going to treat any kind of pancreas cancer cell that's anywhere in your body, and that's chemotherapy. And then we have 2 kinds of local therapy. And there are some other kinds that are kind of being tested out, but I'm not going to get into all of that in the scope of this lecture. But I think surgery is the mainstay, which is, of course, removing the tumor and the tissues around the tumor. And we also have radiation, which is another way to treat the tumor locally without necessarily treating the whole body. So the question is, how should we do this? What should be the sequence of events? So when I was a medical student, which I can now say was like, almost, I don't know, I think it's like 20 years, 20 years ago. But when I was a medical student, we felt that, pancreatic cancer, oh my God, this an emergency, there's a mass, the patient's jaundiced, book the OR. That's really what was done. We did not wait for a biopsy. We didn't mind that they were jaundiced. We didn't go into how much weight have you lost and are you really ready for a big operation. It was just felt like there's a tumor. We got to hurry up and do something so that it doesn't spread. And, what happened back in those days is that, the results were not so good, right? Because what happens when you take someone who's not feeling well, who's lost a bunch of weight, who's not eating well, and you fillet them open and you say, now I connected a bunch of things, now heal for me, right? It doesn't go well. So we saw increased complications, long hospital stays. And during that time, that meant that patient could not get whole body treatment, chemotherapy. So that was often delayed. And sometimes by the time you got their next CAT scan, you would see that, well, now it's in the liver. And so what does that mean? What we've learned over time is that probably many patients, when we see that it's just in the pancreas, it might be that some cells have already traveled and we're seeing the tip of the iceberg, right? And so we really, for the most part, changed our approach over the last 20 years, which is nowadays we know that pancreatic cancer probably did not happen overnight. It probably has been there for some time before we realized that there was a problem. And our tests that we have now are unfortunately still not very good at picking up microscopic disease. I tell people, right, you don't know if I have germs on my hands. I mean, we know I have germs, but you don't know how bad they are. But cancer cells are the same way. The hands can look clean and there might be germs. And so the scans can look okay, but there might be some cancer cells. So the other issue is that patients are not in the best shape. And, during this period, that microscopic cancer that we're missing might show up elsewhere. So now we have a philosophy of saying, let's save the big surgery for the right patients and the right tumors, right? And so we now talk about increasingly, and not every single person, and for those of you listening online, right, we always have to get that disclaimer that no patient can have just a PowerPoint lecture that tells them, what should be their treatment. It's important that you meet with your doctor and figure out what is the best plan for you. But generally speaking, more and more patients are seeing chemotherapy before the big day, as I like to call it. Why is that? It's associated with a higher chance of completely removing the cancer with negative margins, which means at the cut edge of the tissue, we're not seeing cancer cells. It's easier to tolerate chemotherapy before surgery than after surgery. I'm getting a sign already. All right. And then also to avoid major surgery on patients where, and it's only a couple of times a year, but a couple of times a year when I'm meeting someone, again, after a few months of surgery to talk about moving, a few months of chemotherapy to talk about moving to surgery, a couple of patients a year, I have to tell them, I'm really sorry. I'm seeing something now in your liver. We got to pause our plans. But our feeling now is that's not a missed opportunity for surgery. Our feeling now is that means we avoided doing this major thing to someone's, GI tract and their life, because probably that liver tumor, if we're seeing spread there, probably was there 2 months ago. We just didn't see it, right? So totally different strategy. I'm going to skip over some of these things. We wanted to talk a little bit about the surgery and, some of these things. I think we'll make this online so people can slow down and go through some of these pictures. But essentially in the Whipple procedure, we're taking out a large part of your GI tract with the head of the pancreas, the duodenum, the end of the bile duct, and the lymph nodes. And then we have to put everything back together. That has to heal in the body and tail of the pancreas. We typically take out the distal pancreas and the spleen because the blood vessels to the spleen run there. These are some pictures of specimens, which is probably not nice to do at lunchtime, but I'll keep moving forward. Let's talk a little bit about robotic surgery. Lots of buzz about robotic surgery. And I do a lot of robotic surgery. A whole program does. Dr. Abdallah, Dr. Burnett, I think the main thing is that that robotic surgery allows us to do minimally invasive surgery in a little bit of a better platform, I think. And so far, studies show that robotic surgery for pancreas cancer have similar cancer-related outcomes. We definitely have lower rates of wound problems just because the cuts are smaller. We think that patients get out of the hospital a little sooner and hopefully have less blood loss. But one thing to remember is robotic surgery is usually longer. And for people, especially that have pulmonary or lung issues, it's a longer time under anesthesia. So respiratory complications sometimes can be increased. So this is a really individualized decision. I don't want anyone taking away from this that their surgery has to be one way or the other. I think what's important is that you have faith and trust in your surgeon, and what they think is best for you, is what I would normally recommend. Risks of pancreatic surgery, we'll go through a little bit, but bleeding and infection, I think the important thing, as I've stressed, is you got to have good patient selection, picking the right people who are going to tolerate a punch, because that's kind of what I'm doing to you on the day of surgery with a lot of anesthesia and a lot of faith that you won't be mad at me. And you want technical excellence, of course, which comes with good training and seeing a lot of patients and doing this several times a month. And then you want great staff, which of course we have. I think it's important to remember that not everybody's going to be able to have surgery, and it's not the end of the world if you can't, in that we do have other treatments, and the other treatments do help you. It's not so black and white, and I think a lot of people get, very, very disappointed, and rightfully so. I shouldn't say it's not a disappointment, but remember that there are other options, chemotherapy and radiation, that can help you to live longer. And our focus can often be on quality of life as well as how long you live. Some patients may be candidates for clinical trials if they can't have surgery, or if the medicines are not doing a great job. In the future, we're looking at what other drugs do we have other than standard chemotherapy. We're looking at cancer vaccines, which is going to be very cool. Taking a portion of somebody's tumor after surgery and then making it into a vaccine, injecting it into them and teaching their immune system to say, hey, if you ever see that cancer cell again, you show them what's up. So that's not ready for prime time, but it's in testing. And I think we'll look in the next couple of years. New methods of running trials. Shout out to PanCan for the precision promise, capability of saying, how do we pool together a lot of patients and help them get into clinical trials? Closing thoughts. I think the main thing is advocate for yourself. If you've got symptoms, talk to your primary care and escalate if the primary cares are going to get very upset that I'm telling them to escalate over and over again. But no, I do think it's important because honestly, sometimes they may not know, right? If 3 months later you still have a symptom, your primary care doctor may not realize that it's still going on unless you tell them. So I do think it's important. Control what you can, healthy diet. We all need to be doing good diet, good exercise, minimize drinking, smoking, and avoidable toxins. A personal support team, having good faith, family, and friends, finding an expert team, using the internet wisely, right? Using it to help you and not hurt you. Because at some point, the internet can't do surgery. The internet is not going to be taking care of you if you have a problem in the middle of the night because you've had a reaction to chemotherapy. So use it wisely. Use it in a way that helps you and gives you information, but doesn't necessarily distract you from what your clinical team is recommending. Okay, good. I want to just take a second to thank everyone here. I'll take questions if we have time, maybe a couple, and then Allison's going to talk a little bit about a very important aspect of managing patients with pancreatic cancer, which is their overall nutrition. I did. Yeah, I think that's a good question. I think that's, again, it's going to be very individualized. I think that there are patients that especially have smaller tumors that are not involved with the blood vessels could be candidates for, robotic surgery. I think that honestly, we don't have the long-term follow-up in those patients. So I do think it's very individualized, and I'm looking forward to seeing some of the longer-term outcomes in my own patients. But I think we should, again, leave it to the center and your surgeon to figure out what is the best management plan. Not everybody can have that. Honestly, most people probably cannot have a robotic pancreatic operation, especially a Whipple. So I would basically talk to your doctor about the options. It's an excellent question. It's very rare that we would entertain that. I think if it's in, for example, if you have a separate cancer that's in the tail of the pancreas. Yeah, I mean, so if it's right, if it's in the area where, first of all, we've already been there, so there's scar tissue. Second of all, the blood vessels, like if I could just take away the position of those blood vessels, it would be, yeah, I would try. I'll make a phone call. But the problem is, the first time is the best time, right? And so once there's a recurrence locally, it would be very rare, especially in the pancreatic resection bed, to be offering repeat surgery. I mean, I might think about also like a patient who's had a tail resection and now it's in the body. You might think about doing additional body resection, but redo after Whipple is fairly unusual. And I think the main question is, again, are the risks of surgery worth it compared to the benefit compared to other techniques like radiation and surgery? Well, genetic testing, it's a good question. Typically, we talk about any genetic testing discussion happening 18 or older, just obviously, unless it's going to be a kind of syndrome where cancers can start when you're 10 or 15. So I think generally wait for genetic, and I hope, I don't know, Eric is not online, right? Eric can, if you're listening, feel free to join in if you can, but our genetics team, it's a good question for them, but generally speaking, unless we think there's a possibility of like a teenager developing that cancer, we would wait until they're 18 because we want them to be ideally participating in the decision to get screened. And then, depending on what the age was. Like if somebody were to have a pancreatic cancer, let's say 37, we would typically talk about screening at 27, like 10 years before, if there's a mutation identified. It's a little bit more hairy in terms of obviously not having a lot of data if there's no genetic mutation. Then it's kind of like, well, common sense might say, why not take a peek at 27, but we don't have any scientific data to say that we should. And of course, we're balancing the risk of finding like a cyst that then causes stress or leads to a biopsy that doesn't, that causes a problem. So I would say it's a pretty tailored discussion. But I don't think most of the mutations, only rare ones would be considered testing children, younger than 18.
Along that same lines of genetic testing, referring to, you said genetic testing difference of pancreatic cancer or global?
I would say genetic testing doesn't hurt if you have a concern with your family history. So I wouldn't necessarily recommend everybody go get genetic testing. I mean, I will say that it is now essentially available to, anybody who wants it for their own peace of mind, but it's not scientifically recommended because almost all those patients are going to have normal results. So it may not be, and it's not covered by insurance. So it can be a pretty, real out-of-pocket cost. So it's really only recommended, essentially based on your family history. And the reason I refer liberally to the genetics group is because one can only be an expert at so many things, right? So I cannot keep in my mind all of the different syndromes of like that cancer and that thing. Like if your mom had this thing and your second cousin had this thing, what do we do? So that's really the expertise of a genetic counselor. That's what their job is, to be on top of all of those different syndromes. And so they might do a better job at looking at your history. They will do a better job at looking at your history and then understanding, do you meet criteria for testing? And then separately as will your insurance company pay for it, right? Because if you don't meet criteria, those insurance companies are going to have lots of guidelines.
Is there any way that the different hospitals and work together with doctors that are involved? Does that happen at all?
Well, I guess it depends on what you mean. Yes, absolutely. In terms of like, I have patients who get their, who might get their chemotherapy at a different hospital system or their radiation in a different hospital system. So we've had it, we definitely all work together. I mean, earlier today, I called one of my colleagues at Piedmont, and we're really all colleagues. We're friends. We see each other at conferences. So there's no hard feelings. We like working with each other. And so I think cross collaboration is definitely possible. I think the main thing to just remember is that all the different systems have their own internal record system. And that I just always say, if you're going to go to different places, then the onus becomes a little bit more hefty on the patient to try to help with having the binder, getting the reports. I mean, we will do all that, but then we are sometimes waiting on, reports to come through, or sometimes a scan has been read by a doctor. I don't know. I like when I have a finding on a scan that, I'm like, well, I'm not sure how that, what do I think about the vessel? I like going to my few, friends that I have many friends in radiology, but I like to go to a few colleagues that are my go-to, right? And so when I see a name that I don't recognize, then I'm thinking, okay, well, let me, how do I call that person up and just talk to them. So I do think that there's a cohesiveness that comes with picking a system, but it's certainly not impossible. And I think honestly, if the doctors you like are in different places, then you just make sure they're connected, right? And we're happy to do that. I often have Crystal's here. I have Crystal, or she was here, yes. So often one of Crystal's my medical assistant, all-star extraordinaire, and one of her jobs is I say, Crystal, call up that office and give them my cell phone number and tell the doctor to pass on the message that I want the doctor to call me, and it works. Like within 24 hours, like that little post-it gets transmitted, and usually, I get a call within the next 24. We're all happy to talk to each other. It's just, we need that little extra oomph to say, yeah, can you guys make it happen? I want to make sure maybe should this be the last one, just because, do we have time for Allison? Oh, we're okay. Yeah.
I noticed you didn't mention immunotherapy as
Yeah.
treatment options for pancreatic cancer. Where are we with
So that's a great question. So immunotherapy has not thus far so far turned out to be that helpful for pancreatic cancer, at least in the initial trials. And our theory is because pancreatic cancer actually makes a very dense scar tissue reaction that makes it harder for our own immune cells to kind of get in there. So it doesn't always targeting the immune system hasn't always shown alone to help patients with pancreatic cancer, at least not yet. Now, there are some trials looking at maybe combination therapies, and I think that will hopefully be kind of the way of the future. Yes. Sorry. I don't know what, do you want to maybe, I'll do one more and then maybe we can talk offline. Yeah. Let me let her go and then we'll, yeah. I'll find you afterwards. Yeah. Go ahead. No, it's a great question. It's not. It's for any tumor that's in that head of the pancreas. And so that means that it can be for bile duct tumors that are in the later part of the bile duct. It can be for ampullary cancer. Tomorrow I'm doing a patient with an ampullary kind of tumor, which is the ampulla is where the bile duct and the pancreatic duct meet and empty into the intestine. It can be for duodenal cancers. So you know, I always say to the other patients, they sometimes get concerned when they see liver and pancreas. If they have cancer of another organ, what are they doing? Where's the ampullary expert? And I say, don't worry. You know, there is no ampullary surgeon. The ampullary surgeon is a pancreatic surgeon, basically. Okay, I really think it's important to let Alison talk. So yes, please.
To talk about nutrition.
Hi, everyone. I'm Alison DeVries, and I'm the registered dietitian at Atlanta Liver and Pancreas. It's good to be here, and it's so great to get to work alongside such a talented leader and surgeon. And it's really nice to get to work at a practice that values the importance of nutrition. Sometimes that gets overlooked, and nutrition is a really, really important part of treatment of the pancreas because it does have a lot of nutrition related concerns specifically. So I just wanted to give you all some general healthy eating guidelines for cancer treatment, and then talk about some of those nutrition related disease concerns, and then give you some tips for managing side effects of treatments, and that might include medications that we can talk about too. So as Dr. Sur mentioned, treatment of pancreatic cancer might include chemo, chemoradiation, surgery, and all of those things can be very, very stressful on the body. And nutrition can really be a tool in your toolbox to help your body stay strong and tolerate and recover from all of those aspects of treatment. Treatment might also look very different patient to patient, but regardless, everybody needs an individualized treatment plan, and a registered dietitian can really help guide you through what the best plan is for you based on your scenario. A good place to start when we talk about a nutrition plan is with the American Institute for Cancer Research cancer prevention guidelines regarding diet and lifestyle. Be at a healthy weight, be physically active, eat a plant-rich diet, fruits, vegetables, whole grains, legumes, limit fast foods and processed foods, limit red meat, try to avoid processed meat, limit sugar sweetened beverages, drink lots of water, limit alcohol, and don't use supplements for prevention of cancer. The AICR also recommends trying to adhere to these guidelines throughout treatment as a good baseline to support your body during treatment. A healthy diet really sets you up for a good foundation throughout. So I always say the diagnosis period is a really good place to reflect on what your eating habits are and how can you shift those a little bit to come more in line with this. You'll notice these guidelines don't say become vegan, don't say cut out food groups. That's not the time to make drastic diet changes because we want to keep you strong, and diet elimination can cause deficiencies, can contribute to weight loss, but just how can you shift things a little bit to support yourself a tad bit better. As you move into treatment, the nutrition goal becomes preserve weight and especially preserve lean muscle mass. We know that weight stability is associated with better treatment tolerance and response. We know that it's associated with better surgical outcomes and improved rates of survival. We also know that muscle mass impairs functional status and impairs quality of life. But we know that weight loss and loss of lean muscle is very common during cancer treatment. Up to 50 to 90% of patients experience these things. It's very common. So how do we combat that? We put a plan in place. This is a good, simple plan to start with, and then it can be tailored to a patient's specific experience. But this kind of marries a general healthy eating pattern with how do I maintain weight at the same time. Schedule your meals. It's much easier to stay on track when you have a planned eating time. Include high protein foods at every meal and snack. Include lots of plant-rich foods and lots of hydration. That's a really good, easy place to start. To expand on that a little bit, we know that decreased appetite is a very common side effect of cancer and its treatments. So those scheduled meals, those are really important, especially with breakfast. Start your day off right. That can help stimulate your appetite earlier in the day or later in the day. I'll tell a lot of my patients, try to eat breakfast within 30 minutes of getting up. That helps to keep you on track. A lot of times, smaller, more frequent meals are easier for patients to tolerate. So that can be a strategy to implement. Try to plan ahead. There's lots of appointments and things to be getting to during treatment. So do you need to pack snacks to take with you? Do you need to have an idea of where you're going to go get lunch after your treatment? Try to eat your largest meal when you're hungriest. It's always easier to eat when you're hungry. But try to have your last meal 2 to 3 hours before bed so that you don't have symptoms of indigestion and things like that. And then try to eat with family and friends. That's always more enjoyable. Protein. Protein is really important during treatment. Protein needs are a lot higher during treatment. Our cells are getting stressed. They need that extra protein to recover. So try to use every eating experience as an opportunity to get protein. That can be poultry, fish, lean meat. That can be dairy foods, eggs, nuts, nut butters, beans, peas, lentils, soy products, and really a variety of food choices, a variety of these options will give you the better variety of nutrients. So aim for that as well. Some people find it really helpful to use added protein beverages, whether that's making a homemade smoothie with fruit, maybe a handful of spinach with some added protein powder, or commercial supplements. There's lots of options on the market these days that are tastier than the ones that we're all familiar with. There are high protein, low sugar varieties available for people who are eating well and really just need to use the supplements for extra protein. But if you're someone who's struggling to maintain or recuperate weight, try to pick varieties with at least 350 calories. That's a good general range. Plant-rich foods, just some general guidelines here. 3 to 5 cups of fruits and vegetables a day. Most of us don't get that, but it is very important. The more variety, the better. Try to make your plate colorful. That's going to give your body the micronutrients, vitamins, and minerals that it needs to withstand treatment. Also vary your cooking method. Some raw foods, some cooked foods, the way you prepare foods kind of changes how much of certain vitamins and minerals your body can access. So variety is also key. This can also help you tolerate fruits and vegetables during treatment. When you don't have an appetite, a plate of broccoli might not be appealing, but that handful of spinach in a smoothie might be a lot easier to approach. Also try to include whole grains and legumes in your diet on a daily basis. That's good fiber, that's good B vitamins. And then healthy fats can be a really great tool to help maintain calorie intake and weight, especially for people who are struggling to get enough nutrition throughout the day. Avocado, nuts, nut butters, coconut milk, chia seeds, those are all some good examples. And then finally, hydration. This is a tough one because most of us are not well hydrated. It's a really, really hard habit to start because if you are chronically underhydrated, your body doesn't really feel thirst very efficiently. So we can all do a little bit better, but here are some tips. You know, try to hydrate primarily with water, but you can add fruit slices. You can add some herbs for flavor. You can dilute with fruit juices. That's completely fine. Herbal tea, coffee, popsicles, broth, bone broth, those all contribute to your fluid intake throughout the day. And then if you're losing fluids, if there's any vomiting that you're experiencing from treatment, if there's diarrhea you're experiencing with treatment, definitely replace those fluids, but also replace those electrolytes as well. Here are some good products that I've had success with some of my patients. So those were some kind of general guidelines for your nutrition plan during treatment. But as we've talked about, there are some very specific concerns when a disease is impacting the pancreas that might require some more individualized modifications of that plan. One of the big functions of the pancreas is the exocrine function of the pancreas. This is how we digest and absorb our foods. When foods hit the stomach, the exocrine cells in the pancreas stimulate digestive enzymes to be produced. Those travel through the pancreas duct, meet up with bile in the common bile duct, and then meet up with foods in our small intestine where they break down foods to a form they can be absorbed. When that's not happening appropriately, we refer to it as something called exocrine pancreas insufficiency or asynchrony. That's a big nutrition related concern because it leads to nutrient malabsorption. If your body can't absorb your foods, it can't use those nutrients for energy, for cell functioning, and that's a big barrier to treatment. Nutrient malabsorption can cause GI discomfort, intolerance, bloating, indigestion after meals, increased foul-smelling stool, intestinal gas, bowel urgency after eating, light, pale, or yellow-colored stools, or oily and greasy stools. And these symptoms can present along a spectrum. So definitely make note of any changes that you're seeing in your bowel habits. I know that it sounds weird to say, look at your stool, but there's really a lot of information that's very important to all your providers to help give you the best care. Because if you're not absorbing your nutrients, it can contribute to weight loss, it can contribute to malnutrition. So we need to try to correct that. And the way we correct that is through pancreatic enzyme replacement therapy, which is essentially a prescription medication of sorts that replaces the enzymes your pancreas would typically produce. In order to mimic that function, it's a medication that needs to move through your system at the same time as your food. So you need to take the medication every time you eat a meal or a snack or even a protein shake. So that's something we deal with a lot with our patients. Another nutrition-related factor of pancreas cancer is the effect on the endocrine system. The pancreas also has endocrine cells that produce hormones, insulin and glucagon that help to keep blood sugar managed, keep it from getting too high, keep it from getting too low. When this function is altered, it can be very hard to control blood sugar, and that's something we want to try to do because high blood sugar can interfere with healing. It can make side effects of treatment more severe. So here are just a few nutrition interventions that we kind of start with, and with the intent of improving blood sugar control. Eliminate added sugars, concentrated sweets, try to distribute balanced meals evenly throughout the day. Our bodies like consistency, so that really helps. A per meal carbohydrate limit might be appropriate for some people. And then moving after meals is really helpful too. It helps our bodies become more sensitive to insulin. So even 5 minutes of walking after eating can really help to lower your blood sugar. And then a lot of patients do benefit from an endocrinology evaluation, whether that's starting medication or modifying a medication regimen that's already in place. Something else we have to think about in terms of our nutrition plan is the side effects of treatment. Both chemotherapy, potentially radiation come along with a lot of side effects. Here are just a couple: poor appetite, taste changes, nausea, vomiting, early satiety, bloating, diarrhea, constipation. There's a really wide range and everybody's a little bit different with what they experience. I did want to expand upon two that I hear a lot from my patients that make it hard to eat. One is taste changes. This is really common, kind of weird side effect of treatment. It impacts everybody differently. It can be different after different treatment cycles. Something that tasted good at the beginning might taste differently at the end. So a couple tips to help with this. First, good oral care. The stress of treatment really changes the microbiome in our mouths, and it creates a situation where there's a high risk for bacterial overgrowth, something called thrush. So monitor for signs of that. A coating in your mouth, that's something that we have medication to address. So let your provider know if that's something that you notice. Also, just good oral care in general. This is a recipe for a great, simple, make at home mouth rinse that you can use with water, salt, baking soda. The baking soda is a great neutralizer, so you can swish and spit before and after eating, and that can help with taste changes too, to start on a clean palate. The second part of this slide is a method known as the FASS method. These are some tips for kind of combining flavors and modifying flavors based on the taste changes that you're having. Foods are tasting metallic, add sweetness. Too sweet, add acidity. Too salty, add some lemon juice. Too sour, add a pinch of salt. And this can be really helpful because you can modify these things based on what is working for you at the time. The other thing I just wanted to touch on briefly was diarrhea. There's lots of different causes of diarrhea during treatment, whether it's pancreatic insufficiency and malabsorption. It can also be a side effect of chemotherapy. It can also be due to surgical changes or infection. So really try to monitor characteristics of diarrhea. What's the timing of the onset of your issue? Is it something that is new now that you started chemotherapy? Is it something that's new now that you've just gotten out of the hospital? That can really, again, help your providers come up with the best plan to address that issue for you. Nutrition interventions to help with diarrhea, enzymes if needed, increasing soluble fiber-rich foods. This can help bulk your stool so you're not losing as much fluid in your stool. Lower fat meals are likely better tolerated. And then again, replacing fluid losses with electrolyte-rich beverages. Finally, I just did want to touch on our nutrition protocol at ALPS when it gets time for surgery, whether it's a distal pancreatectomy, a Whipple, a total pancreatectomy. These are big surgeries that are very stressful on the body, especially as someone is likely coming off of other treatments prior. So we do spend a good bit of time talking about nutrition and building up our patients before surgery. This usually involves a high protein diet. I'll often give patients a very specific goal to try to achieve as they work up to surgery. Distributing protein evenly throughout the day, that can really help our bodies utilize protein much better. And then almost all of our patients before surgery will get some form of protein powder supplement or a liquid supplement to help reach those higher protein targets. We encourage activity along with this protein intake. We like to compare surgery preparation to getting ready for a marathon. How can we build our bodies up and get ready for that stressor? And then we also recommend a wound healing supplement called Juven that helps the body's tissues heal much more quickly after surgery, but we'll have patients start this about a week before their surgery date. I also spend a good bit of time before surgery, discussing with patients what post-surgical diet will be. When you're changing digestion, the digestive tract so much, you do kind of have to reboot the GI tract for optimal digestion. So we start with a really soft, bland diet after surgery, 6 to 8 very small meals a day, hydrating liquids in between meals, not along with, because that can promote satiety. Really limiting concentrated sweets, because that can alter blood sugar, make it more difficult to heal. It can also cause some GI intolerance. And then really optimizing medication management with enzymes, with acid suppression, and with motility agents if needed. And this is a plan that, aspects of this are relevant in the long term, but we really try to work with patients along with their healing and recovery, so they feel really confident with a nutrition plan that will work for them in the long term. So that's about what I had today, but in summary, a dietitian is a very important part of the care team. If you're treated through the Northside network, you have an oncology dietitian available to you. If you haven't met with one, you can ask your doctor for a referral. We're good people to have on your team. If anybody has any questions, I know we're running out of time, but I would be happy to answer anything.
Hold on and do questions after in a little bit.
Yeah. Yeah. Whoops. Yes, you're okay.
Thank you so much. And now we're going to hear from a patient of Dr. Sur's, Alicia Turner, who has so kindly agreed to share some thoughts. Whoop. And I'm going to give you this, Alicia, to put on too. Wearing her purple beads.
And my bracelet.
Her purple band, yeah.
Good evening to those who know me. Hello. I've ran into a lot of people over the last couple of months. And then there are new people, new faces. And I want to introduce myself. I am Alicia Turner, one of Dr. Sur's patients. I am a 3-time cancer survivor. I was first diagnosed with breast cancer April 20th, 2018, which was on my birthday. So I never forget that one. The second time with breast cancer was 5 years later. And I'm listening to Dr. Sur, all the good information that she gave. And this is stuff I've been hearing. You're thinking in 5 years, I'm clear. And it was on the 5th year checkup that I'm looking to be in the clear. But I was diagnosed with the second time breast cancer, and this one was more in depth. It required surgery and reconstruction. So, I didn't give up. I stayed prayerful. I am very much a praying woman. So I did not give up. September the 27th, saw this on the slide, I was itching. My urine was very dark. So it was like symptoms. I didn't know this at the time, so I went to my primary doctor. My primary sent me to the ER. Walking to the ER at Northside, I stopped, left the doctor's building, came over to the emergency room. And I said, Lord, I don't know what this is, but I'm going to stand on my faith. And I know we're going to get through this. And that's what it is, what I stayed on. Not knowing that it was going to be pancreatic cancer. I was like, okay, I'm not going to waver. I'm not going to give up. I'm going to stand on my faith. After being admitted into the hospital, I don't know if you're familiar with this story in the Bible, but Hezekiah turned to the wall and prayed, asked God for extension on his life. And I thought about that. I said, okay, I don't know where it is right now, but I'll find it. But it is in second, where did I find that? As I'm going to go, it was 2 James, 20th verse, that he became very ill, almost at the point of death. And he was also told to get his life in order because he wasn't going to survive. Back in the days, a lot of people did not survive pancreatic cancer. It was like a death sentence. I heard Dr. Sur say that, I guess they rushed him on in when they said that, I don't know. But that was a thought. And I said, people didn't survive back in the days. I said, but today I stand here as a patient who did. I survived pancreatic cancer. And I'm so thankful. And God, as I'm standing on my faith, I have endured 6 months of chemotherapy total, 6 weeks of chemo and radiation at the same time. I've had my gallbladder removed. I've been through 8.5-hour Ripple surgery that we all know what that is now. I didn't in the beginning, followed by 4 rounds of chemo ending August 22nd, 2025. So I just finished. My medical oncologist said, Ms. Turner, you've handled everything with grace. And I told him that was with God's grace and mercy that I was able to do. I consider myself blessed. God heard my prayers. He shielded me from the most common sickness that comes with cancer, being the vomit and the diarrhea, the loss of weight, the loss of, he shielded me from a lot of that. And I'm thankful, very thankful. I didn't lose my hair. I've lost a total of 13 pounds doing this whole thing. I kept a strong and positive attitude every day because I knew every day was another opportunity. It was another day at life. God has healed my body and he's granted me extension. All I can say today is to God be the glory. He gave me a good doctor. That was one of my prayers. God gave me a great doctor, excellent bedside manners, because we're gonna bump heads. If not, Dr. Sur had the pleasure of meeting my sons. They were going to bump heads. So God knew what he was doing. And I am just blessed, I'm thankful, and I can't say 1 year later, I'm still here. Be encouraged, I tell everyone, be encouraged. Hold on to your faith or whatever you believe in. If it's not faith, some Jehovah, whoever, whatever. I said, there's a higher being than we are. Hold on to it. And just don't give up. God will take care of you, or your higher being will take care of you. May God continue to bless and keep you all. We all have made it through. Today, I'm very thankful. Thank you. Thank you so much. Thank you.
I want to thank Alicia real quick because sharing your story is something that takes a lot of courage. And I also think that you are a testament to why emotional resilience is such a critical part of getting through this journey, right? If you have been faithful from the beginning, you've been optimistic from the beginning, you've asked every question. It wasn't that you just did whatever. It's not that you just did whatever we asked you to do.
Right.
You asked all the questions and you questioned us, which is what you're supposed to do.
Okay.
But you thought about it and you went along with
Yes.
the plans after weighing the risks and the benefits.
I did.
And you never lost sight of that. And that's very, very important because, you know, if we're falling apart emotionally, it's very hard to rally the strength that is needed to get through chemotherapy, radiation, and surgery. I mean, you did it all.
That is true.
And so you're sharing your story is, I think, very motivational. I'm sure you would all agree, very inspirational for someone who's starting out on their journey. And she's a famous documentary photojournalist. And so
I scrapbook. Scrap. I don't FaceTime, but scrapbook.
You may end up in her album. So put your makeup on. But I think that's all a part of that's how you dealt with the stress of everything that was going through, that you were going through. So I thank you and congratulations.
You know, I'm gonna say, Dr. Sur, she came in to discuss taking my gallbladder. I said, no, I'm doing chemo right now. And she's like, well, we're gonna have to stop chemo. I said, but then you're gonna slow down the process. And she said, but I need to go ahead and take your gallbladder out. I was like, no. Like I knew. I got in trouble then because she reported me to Dr. Mahmood. Okay, I'm just telling y'all the backstory right now. So But she educated me. And I told her, because that's going to be 6 to 8 weeks to have surgery. And then, the scar, and then 6 to 8 weeks to heal before I can finish chemo. Doctor says, no, you're talking 7 to 10 days. You might skip 1 week because chemo is every other Monday, but you'll be back. I said, 1 week? I said, wait, doctor said, come on in. Educate me. This I didn't know. She said it was robotically done. And she explained to me the whole procedure. I felt better. That afternoon, Dr. Mahmoud came in. Oh, I heard that you was giving Dr. Sur a hard way to go. I said, we've worked that out. I said, I've already agreed. I'm going to sign the papers, and I'm having my gallbladder removed tomorrow, whatever day it was. And he said, okay. And I started laughing. I told my son, I said, follow me. But Dr. Sur,
I called him the Army.
she has been wonderful. My whole family loves her. And the boys are very comfortable with Dr. Sur, asking questions, and getting the answers. And of course, like you said, Dr. Internet, that's like, no. Yeah, so we don't do that. We're like, let's go to the real source. But I do appreciate it, and she's allowed me to do this. And I couldn't keep it to myself. I just couldn't keep it to myself. Thank you all for your time.
Last question. Thank you all for coming, taking the time out of your day to show up means a lot for our patients, and as well as those of you who have joined online. Okay, we have lots of events coming up. Check out the website.
Yes.
Check out the Cancer Support Community website, and then also PanCan. We'll see you in April.
Yeah, purple stride. Thank you again. Thank you again to Dr. Sur so much for being so generous with her time and expertise today. Thank you to PanCan for partnering with us. We want to see all of your faces at Purple Stride April. Thank you, Allison, for your piece. If Allison, do you have some time to hang out? Do you have a couple minutes to hang out? If people have questions, you can feel free to find Allison. Thank you so much, everybody. It was a great teamwork. So thank you for being here.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.